Good morning. I thank Dr. Rishigoy and Dr. Lekes for inviting me to this session. So what is so special about posterior polar cataract? Like Dr. Alex said, it's overdiagnosed or underdiagnosed. But the thing is, it has got, in all other cataracts, we go and make posterior capsular end. Here is a cataract where there is a posterior capsular dehiscence already there. So we'll discuss some of the practical points in this. Let's start with the diagnosis. Most of the time it is over, but the congenital posterior capsular defect is 35%. And what is important is you should not try to think, in this case, posterior capsular defect is present or absent. In all cases, we assume there is a posterior capsular dehiscence and we have to proceed accordingly. So we have to preparation, both the patient as well as the surgeon. For the patient, we have to talk to him. We have to counsel him in all these aspects, but the important thing is we always tell it's a two-stage procedure. You may require a second surgery. You may not implant the lens in the first stage. So let him sensitize that. For the surgeon, since it's going to be a posterior capsular end, it's always ideal to have a vitrectomy machine. If the surgeon is confident he can handle it, if not, it's better to get the help of a VR surgeon first. And always heavy density viscoelastic should be in hand. The surgical principle is there is a posterior capsular end and we should not push the nucleus into a vitreous cavity. That should be the principle. Accordingly, we should start. So how to do it? So anesthesia. Since the surgery can take time, it's always better to have a perivalvular anesthesia. The incision should not be leaking. There should not be any room for anterior chamber collapse. And the capsular excess should be 5 to 5 mm diameter and slightly oval. It helps him to visco expression or cortical aspiration. It doesn't put strain on the zonules or the existing defect. And finally, there should not be any hydrodissection. So it's only hydrodelineation. Instead of outside in, it's better to have an inside out delineation. The phaco technique. It's always ideal to have a low parameter, and it should be, the phaco should be a non-rotational phaco. And always try to chop anterior to the anterior capsule. Pull out and chop. And then the aspiration should be from the periphery to the center. And in the soft cataract, it's better to attempt a visco expression. It's much easier and safer. And the cortex adjacent to the posterior polar cataract should be the last one to be aspirated. And all these throughout the procedure avoid anterior chamber collapse. So there should be a technique. So parameters we talked about, but one simple point is there, how low it should be. It should be enough, because it differs from each machine to machine, and you should have enough power to break it. If you have a low power, you'll be pushing the nucleus in. So that is one thing. And another thing is, if your vacuum is not sufficient, you will not get enough purchase. So that will also put strain on the capsule. So these things a surgeon has to titrate to his advantage. It also depends on the sclerosis level of the cataract. Yeah. When you don't have enough power, this is what will happen. You will not get adequate chopping maneuver. So better have, in children, it is 7% of the congenital cataract, they have posterior polar cataract. Cervical rexis, we know, and it should be more of an aspiration. And visco expression will be ideal. And do a posterior capsular excess. Finally, SACS. When you do SACS, how to do it? The same principle, only thing you have to be careful with the nucleus prolapse. And cortex should be aspirated through the side port mostly. And in this case also, you should avoid anterior chamber collapse. So in summary, there should not be any hydrodissection. The phaco parameter should be low. The phaco should be non-rotational. Anterior chamber collapse should be avoided. And if the nucleus drops into, don't try to retrieve it. Ask for a VR surgeon. Thank you.